All right, I know more people are going to be signing on, but let's get started. I do want to get us out of here at a reasonable time. Um, so I know that Dr. Andrew can't make it, but I do know that Dr. Phillips, are you on yet? She'll be doing the report from the ASU. Okay, I know she'll be tuning in. Dr. Atenito from FAU. Doctor, are you on? Okay, this is kind of a useless gesture because half the folks that I'm calling I know are going to be here. So, okay, Tom Baird, Attorney Foster, Jones and Foster, Municipal Attorney. Okay, Turner Benoit from Hanley. Turner, are you with us? Yeah, there you are. Unmute yourself, Turner. Say hi. Or not. Okay. Now, Ann, I believe, was called away. Who's here from South Florida Behavioral Health Network? Seth Ben. Okay, who will be here? We will find out. Okay, Ariana, you with us? Ariana Ciancio, Delray Beach Police Department,
I
Public.
am here.
Hi, Ariana.
Hi.
Who's with us from the healthcare district? I know that again, Dr. Andrick is not going to be with us. I don't know if Darcy Davis will, but I know that Dr. Phillips will be with us. Courtney Phillips. Okay. Uta Gasiak. Uta, you with us from Florida Behavioral Health Association?
Good afternoon. I'm here. Hi,
All
Al.
right. You're one of the early birds. Thank you so much. Now, I don't think Lori Hunt is going to be here, but I saw Michael Makia. Michael, you with us?
I am.
Okay, you'll be
Yes.
giving us the update for Oxford House.
Yes, sir.
Okay, John Hulick. I know he's been a busy guy with the. There you are, John.
Greetings, Al. I am here. Thank you.
Yeah. I just want to let you know, my friend, you're making me crazy by sending me 170 pages 2 days before the meeting. But just
A large part of that, Al, is appendix, my friend.
I know there's 76 pages, but still. Okay. Anyway, there's a big meeting from the Palm Beach County Community Services Department regarding the opioid dollars tomorrow at the Mandela Center. Many of you I know about it. Okay, Florida Association of Recovery Residences. I saw Heidi, you're with us.
Yes.
Al, Mike is here as well.
Okay, Micah, fresh back from your trip to Tallahassee.
You better believe it.
Better late than never, right?
That's
Okay.
right.
Welcome. DCF, I saw Molly McKistry. Are you with us?
I'll also have Courtney Smith on for a bit when I do.
Okay, great. Okay, DCF is represented. Jeff Lynn, I saw you were the first one on.
Hello, sir.
Okay. CEO of Rebel Recovery, Nancy McConnell. Nancy, are you with us, or is there anybody from Rebel here?
Austin's here from Rebel. I think Nancy will be joining.
Okay. Thanks,
in a
Austin.
bit.
Appreciate it. Neil McGarry, Florida Certification Board, FCB. Neil, are you with us? Okay. I saw Dr. Moran had signed on. Dr. Robert Moran, you with us?
Yep. Hi, Al.
Okay, hi. Dr. Rachel Needle. Rachel, are you with us? Okay, I'm sure she'll be signing on soon. Houston Park, DOH. But I know we do have Dr. Shepke here representing DOH, and thank you for tuning in, Doc. Appreciate it. Terrell Pyburn, Coconut Creek City Attorney.
Hello, good afternoon, Al. Unfortunately, I have to leave at 1:30, but I'm here for a little bit.
Okay, well, and if your meeting ends early, this is going to be a fairly long one, so I think we'll be here past 3:30. So, just
thank you.
In case you're available, feel free. Susan Ramsey, victim attorney, I'll say. Susan, are you with us?
You could also say I'm general counsel for the Florida Association of Recovery Residents.
Can we make a note of that? So, okay.
So good. It's official, and I get a little tag, and that kind of thing.
Yeah.
Maybe I get a tattoo.
So I'm not looking at a piece of paper that says attorney.
Okay.
Okay, Terry Shapiro, with Vita Recovery.
I'm here. Thank you.
Hi,
Good to
Terry.
see you.
Nikki Soda, I saw you tune in from the Kennedy Forum. Nikki,
I'm here.
cool. Dr. Simonides, John, are you with us? I thought I saw you tuning in. Okay, he's with the FSAM. Hopefully be tuning in a minute. Alton Taylor, Drug Abuse Foundation. Are you with us, Alton? Okay, Jan Tolman, Project Opioid South Florida. Jan? I saw Lori Vinacore, Dr. Vinacore, Alliance of Del Rey Residential Associations.
Yes, I'm here.
Hi, Lori. I saw you were in your car. Be careful, will you?
Hello. Yes, yeah, I'm home now.
Oh, good. Okay. And Mayor, former Mayor, Commissioner Greg Weiss.
Good afternoon. Good afternoon, Al. I'm here with you.
Good. Good to see you. Okay. Richard Worms, I saw you were on from the Attorney General's office.
Yes, sir. I will have to, I'll stay logged in, but I have some visitors coming in at 3 that I have to guide in a certain direction, but I'll stay logged in case I have time to come back before you end.
Okay. All right, good. And Eric Urlano. Eric? Okay, we got a lot of good things happening. I want to start with the update. Let's put those slides up there, please.
Which one are we starting with? Because now I have no images. Hopefully this is going to show up.
Oh, there we go.
Okay.
All right, I'll go quickly through some of these because we introduced them last time. We have our own analyst here at the State Attorney's Office who goes through the numbers. Let me pull this off of the screen here. Okay, take that and put it somewhere. Thank you. All right, we just have top of the line equipment here, and we have one overworked person trying to get it all done. Not me. Okay. It's just a snapshot of some of the, we did get the 2022 numbers from the Florida Medical Examiners Association. We did want to call attention to some areas of concern. Number one, we were down slightly from 2021, which is great. I mean, it's good news, but down 3%. 6,162 opioid-caused deaths in 2022, which averages 17 per day. Wanted to call your attention to one out-of-control place, Pasco Pinellas, where there were 765 opioid-caused deaths, up 6% from 2021. Broward County had 568, which was down 6%. But we did call attention to Broward because they're ahead of us. A few years ago, we were number 1 in the state. Now we are number 5. Okay, just Palm Beach County, we had 431. That was adjusted upward. That was a 17% drop from 2021. Duval, Clay, Duval, Nassau counties, 543, which was up 1% from 2021. Hillsborough County, 525, was up 14% from 2021. And Escambia, Okaloosa, Santa Rosa, Walton, I put them there because that's a lot for District 1. And they were up 13%. So there is an issue up in the panhandle that we all have to be looking at, both from a provider point of view and also FAR and Oxford House, because there probably is a demand that's not being filled in that area. Okay, let's move on to the next slide, please. Oh, let's go to the next group of slides, please. We're going to figure out a way to do this more expeditiously.
Well, this is my problem.
All right, I'll do it. Let me.
No, I can see it. I just don't know what I'm looking at.
No, I know, but I know what they are by the name. So, isn't it interesting that we're having this conversation front of the whole task force. How do we get that on the screen? This one here. There we go. Okay, this is something that we put together because I wanted to go back to the beginning to show where we're heading as a state and also where Palm Beach County plays into this. If you look back to 2017, Palm Beach County was in awful shape. 15% of all deaths statewide due to opioid were in Palm Beach County. We had 647. That was the largest number of deaths in the last, well, including 2023. Anyway, in 2018, Palm Beach County reduced 38% to 401. The state decreased 12% in 2018. In 2019, that was a bad year. We increased 16%, and the state increased 13%. Now you look at the far right, you see per day, to give it some perspective. In the height of the OxyContin crisis, I believe the maximum was 11 deaths per day. So we far exceeded that. Going forward to 2020, we decreased 21%. The state decreased 30%, and there still was 17 per day. That state number is wrong. I think that should have been an increase of 30%. I'm sorry. Okay. Oh, yes, it is an increase. I'm sorry. We increased 21%. The state increased 30%. That was the height of COVID. We rose from 12 per day to 17 deaths per day. Then in 2021, we went down 14% here in Palm Beach County. And the state rose 4%. Still taking away the fractions, we were 17 deaths per day. Same thing in 2022, 17 deaths per day. State went down 3% to 6162. We went down 17%. So we had a couple of years where we were rocking and rolling bad numbers, for sure, but way ahead of the state curve in terms of writ large, the number of opioid overdose that caused deaths. I did put down those bottom three statistics percentage-wise, just to show that we're now 7% of all deaths statewide in Palm Beach County, where we were 15% in 2017 and 18% in 2021. Anyway, let's go to the next slide, please. Hopefully these are all together. Yep, there they are. All right. Some of this was from the last session, but we have new numbers from Palm Beach County. But as we were talking about in the larger slide, the 10,000 foot of the state and the county, we were down 14% in 2021, down 17% in 2022. Trank reared its ugly head with 40 OD deaths in 2022. The fentanyl analogs were growing, NPE and fluorofentanyl to 20 and 100. Those have improved. Let's go to the next slide, please. And these are all available on the website. If you didn't get them, you should have gotten them as well in the attachments. But I put this here, which is not, yeah, there it is. I want you to look at the second bolded numbers. Last time we were here, we had many more pending cases. This is the 2023 numbers. We're way ahead in Palm Beach County with the state. We don't expect the state numbers to come out from the medical examiners until November. Actually, they came out in January this past year, or for the 2022 numbers. But we do have a snapshot with 10 pending cases, and I'm told that they're not suspected opioid overdoses, which is great news. But we have a projected 407 total, which is the best number since 2018. and 17 and 18, we're down 6%. And that's on top of the 17 and 14% in the 2 previous years. If the numbers hold, well, actually, if 7 out of the 10 pending cases come back, because 75% of total ODs in Palm Beach County are opioid overdose on average. So we have 400 right now. We could be as many as 407 based on the projected numbers, but based on what I'm hearing from the medical examiner, it might be closer to 400, which would be good news. Again, total fentanyl deaths when you have opioids present is still running in the 92 to 93 range, both statewide and with Palm Beach County. Good news is xylozine's going down, went down slightly in Palm Beach County in 23. NPE went down to 0. We haven't seen it in 2023. And fluorofentanyl is down 35%. So that's heading in the right direction there. That should be the last slide. Okay, now let's go on to an update from FAR.
Yep. Do you want me to share my screen?
Unless there's any questions about the stats. No hands raised. Okay. Heidi, are you doing the numbers?
I can. I can share my screen. Yep.
Please.
Sure. Let me get there.
And while you're doing that, you guys keep on rocking and rolling. Every month you go up in beds.
Yes. Can you see that? Everyone
Yes.
can see this? Okay, great. So we're currently up to 231 providers throughout the state as of March. We have 1,885 units across the state, 9,302 beds. Level 1, 2, and 3, we have 1,085 units, 6,019 beds. And level 4, we have 800 units, 3,283 beds. And I have to move this. Okay, so in Broward County, still has 30% of the units and 29% of the beds. Palm Beach County is still holding at 41%, excuse me, of the units and 38% of the beds. Palm Beach County providers, we have 115 certified providers in Palm Beach County, 787 units, 3,575 beds. Out of that, 1,629 are men, 610 are women, and 1,312 are for both programs that provide both men and women. LGBTQ, we still have just 24. Level 1 in Palm Beach County, we have 6 programs, 27 units, 79 beds. Level 2, 62 programs, 330 units, 1,801 beds. Level 3, 6 programs, 38 units, 129 beds. And level 4, 41 programs, 392 units, and 1,566 beds. As far as our state trends go, I'm in the essence of time, I'm not going to go through line by line. I believe everybody received a copy of this. Excuse me, but you can see Broward is at 2,745 beds, still holding, and Palm Beach County's 3,575 beds. Our progressive, go ahead.
Also, and Heidi too, just I know want to address the Panhandle real quick. If we could just do a quick brief on the Panhandle area.
Sure, absolutely. Up in, let's see, we are growing in that area in the Panhandle. Collier County, 65, Clay County.
Escambia County.
Escambia, 60 beds there, 13 units, and 23 mat beds. We are growing in that area. Our consistent growth throughout over the course of the years, you know, say we started in 2017 with 3,280 beds. And in March of 2024, we have 9,302 beds. Just since January of 2023, we've increased capacity by 11.4%. Our overdoses is self-reporting overdose numbers from January of 23 to March of 24. We had 46 total male, 39 of them were male, 7 female, 14 resulted in death. Boynton Beach, we had 3, 1 death there. Bradenton, 2 overdoses, no deaths there. Clearwater, 1 overdose, no deaths. Coral Springs, 1 overdose, 1 death. Delray, 8 overdoses, 1 death. Fort Lauderdale, 2 overdoses, 1 death. Fort Myers, 1 overdose, 1 death. Jacksonville, 3 overdoses, 1 death. Lake Worth, 2 overdoses. Lantana, 1 overdose. Miami, 1 overdose. And Oakland Park, 2 overdoses. Pompano Beach, 7 overdoses, 2 deaths. St. Petersburg, 1 overdose. Tampa, 2 overdoses. Vero Beach, 1 overdose. West Palm Beach, 2 overdoses. West Park, 1 overdose. It still seems to be opiates and fentanyl as the drug of choice throughout the overdoses. And the average age, we've increased, as far as state of origin, we've increased where these individuals are coming from.
Well,
And that is my report.
okay, Heidi, I've got a couple of questions, and oh wait,
Sure.
first I see a hand up, Dr. Shepke.
Thanks very much for that report. Can you tell me what's the difference between a bed and an MAT bed, and go up to Escambia County again, because it looked like there's 0 MAT beds?
Medically assisted treatment.
Yeah, no, I know it's medically assisted treatment, but what's the difference between being a bed and being a medically assisted treatment bed? Are you saying that there's beds, but you're not allowed to take medications while you're in those beds?
That provider doesn't support MAT.
Are those providers that have beds, but they don't support MAT, receiving any state funding?
No.
Okay.
To the best of my knowledge, no.
Thanks very
Because it
much.
would be federally discriminatory if they were.
Well, it's more than federally discriminatory. It's a violation of the standard of care, I'd say.
And Al, may
So
I?
hold on, Doc.
Yeah,
Oh yeah, go ahead, Susan.
Hang on, everybody, please. In the interest of time, let me just interject a couple of things. And then you have to raise your hand if you want to be heard. Otherwise, we'll be here till 6 o'clock. One thing, Dr. Shepke, is in our legislation that was passed and is being sent to the governor for signature is going to be a requirement within a certain date that all FDA approved, appropriately prescribed medication for medication-assisted treatment must be accepted by recovery residences, by certified recovery residences, actually all recovery residences.
Thanks, Helen. And that'll address my concern. Appreciate it.
Yeah. Now, Terry, briefly go ahead, and then I have a couple of questions for Heidi and for Micah.
Yeah, thank you, Heidi. Thanks for your report. I'll be extremely brief. Two questions. One is what qualifies as a unit? If you can define unit versus bed. I know what beds are, but
Sure. So the units are like the apartment or the house, if you will. That's what defines a unit.
So in an apartment building, a 3-flat apartment building would be 1 unit?
No, it would be the units inside. So if you had a 3-flat apartment building, it would be 3 units.
Okay, got it. Thank you. And then go ahead, Al.
Yes.
If you have a duplex, okay, that would be 2 units, right?
Correct. Yes, sir.
When you're talking about 3 apartments, you mean 3 separate apartments. Each apartment individually would be a unit?
Yes, sir.
Okay. Just want to make sure everybody's on the same page.
Yeah.
Okay, Heidi, and then last question. I not familiar right now with the current FAR standards of care. Do you have, when there is a sentinel event, an overdose and or a subsequent death, are the owners and operators required to do a root cause analysis and report back as to, what happened and what are they doing about it and how are they going to improve their their
Yes.
procedure, policies and procedure. They do, okay.
Yes, within 24 hours, any 911 call to a provider's home, they're required to report that to us within 24 hours and with an explanation of how they're going to address their community and what they're going to do to support the clients.
But not a, root cause analysis as to what happened, what
Oh,
failed
yes,
in their
of course.
system or.
Details of the event, of course, absolutely.
Okay, thank you. That's
You're
all I
welcome.
had, Al.
Okay, thank you, Terry. Circling back to Dr. Shepke's question, we have had, and I think everybody who's been at these meetings, for several meetings, we have had discussed this issue because there have been houses that say we are MAT, we accept MAT, and then we come to find out they only accept Vivitrol. They only accept the antagonist. And that's not MAT. That's just one form of MAT. So we've been working on that. It's changing minds, changing hearts, especially if there's no government funds that are involved. But it will be statutorily required of all recovery residences to call themselves that. So anyway, just to circle back that we all recognize the problem that there are too few beds that accept all forms of MAT, and we're working on that problem. The other questions I had for you, Heidi, were, and this is for Micah, you too. You mentioned the Panhandle. Are there areas where you are concerned, and this is something that I also will be addressing with the department, but are there other areas of the state? Because when you look at 70% of the beds are in 2 counties. Is there a demand that's not being filled? And do you have any idea why this is?
So there's a couple of reasons. A great question, Al. Some of these issues certainly just revolve around demographics. You know, our major metro areas have the most concentration of housing. Our rural areas are less underserved. I'll also defer in a moment to our partners over at Oxford House. They serve a lot more of the rural communities, which is fantastic. But we're looking at those various areas too. And as we're looking at tracking the areas of overdose and usage, the Panhandle is on the increase. We're also coming to realize that you know, over time, just increasing communication with partners in that area has been tremendous. One of the things we've initiated is a statewide all-call for all our providers. So we're now getting participation statewide. So the network is now communicating on where there's areas of need. So for example, there is a large group in the Space Coast, and that is growing. But with that growth, there's a lack of a large number of FAR certified houses. So we're putting some concentration of education up there. I'll be personally heading to the Panhandle probably in the next few weeks as I take the roadshow further. That's to gather not only providers of treatment, those referring, but also to discuss the situation with our currently certified houses and how we continue to build the fold. Some of the challenges that are happening, of course, are just the issues around property cost, insurances, and being able to create a good, strong program, to standard. And we want to make sure we're supporting anybody that is looking to get into the space as best we can, not only through what we can do at FAR, but also through our network of providers to help mentor those programs as well. So we follow the data just as well. And the last part of that, Al, is that we are now working very closely with each of the DCF licensing regions around the state, joining in on their monthly calls and getting information from them, so that we're also adhering to those needs that they're seeing in their regions.
Okay. Great. Thank you, Micah, for that. And here's something that my office did a number of years ago, I think 3 or 4 years ago. It was informal, but we looked around the state, and this the department gave us the data of the intensive outpatient programs around the state, like how many component licenses there were. And then we would look at the overdose deaths, and that would be a good indicator of where we were falling short in terms of one critical area, which is housing, in terms of recovery. And certified housing is what we're actually talking about, rather than just houses that could be flop houses that are opening up and referring and accepting referrals. So I think it might be time And I know that that FAR and the department have a great relationship that has been happening over the past several months. And perhaps that's something that you can do. Any help that we can be at the state attorney's office, I'll be happy to help. But to get that data to look for where the intensive outpatient programs are and the day or night programs, and then see what resources you have from FAR and Oxford House in those
So
regions.
also,
Might be helpful.
absolutely. Al, I want to address that real quick too, is that we're crosswalking those lists thanks to DCF getting the most current data listing of those facilities. So crosswalking that, the housing, and also we're crosswalking the recovery community supports, the RCOs, RCC supports in those areas as well. So we, like anything we're doing here in Palm Beach County, we want to take statewide, which is this, view of an integrated network of support too. So absolutely, it's
Awesome.
it's something we're working on. I give hats off to Heidi and Josh on that. They've been combing through those lists and also making sure we have corrections in that, even within the DCF list, contacting those providers and making sure all the information's up to date and accurate as well. So absolutely.
Okay, and by the way, those at the meeting that missed the last meeting when we introduced Micah, Micah, you're the new CEO, right? Not executive director, but CEO.
Don't tell anybody.
Okay.
One moment.
Don't tell anybody. Don't tell anybody other than
yes, that's other than this whole group.
The secret squirrels
yes,
here.
That's
right.
the rule.
All right. Well, welcome.
Sorry,
by
are
the
you
way.
there?
Okay.
Good. Let me just hear you.
All right. Now, with no other hands, Terry, you.
Thanks for holding. What is your name?
Whoever's got your mic live and is talking, please mute yourself. Thank you. Okay, let's
Are
move
you a
on.
current patient or new patient?
We know who that is.
I'm sorry?
Dr. Simonini's line.
I got it.
Okay.
It's Dr.
The intake process in order.
All right. We got it all happening here. Okay, let's move on to
Al, just have that Marianne mute everybody. It's easy.
I did.
Okay, let's move on to Oxford House. We have Michael.
Hey, Terry's hand is still up. Al, I don't know if he's done. No, you're done.
Okay. No, he didn't take his hand down. Okay. All right, Michael, you got an update for us? Thank you.
Sure. Yeah. Well, congratulations on the legislation getting passed. That's awesome. So where we're at here in Florida with Oxford House, we're currently at 173 beds, or 173 houses with 1,563 beds. We have 108 men's houses with 970 beds, 24 women's houses with 209 beds, 38 women and children's houses with 355 beds, and then 3 men and children's houses with 29 beds. Couple new areas I believe that we've opened up since our last meeting: Port Charlotte and Fruitland Park, which is Lake County, central part of the state. Maitland, right outside Orlando. And we do have a couple houses in Okaloosa County, Crestview, and then about 10 in Pensacola, Escambia County. And we definitely have been looking at some more rural areas of the state, and we continue to want to try to find areas that need housing, need recovery housing, and really work on providing that in areas all across the state that are just completely underserved. And so we're able to do that pretty effectively, continue to try to do that. But the Oxford houses in Florida are experiencing positive momentum with various noteworthy developments. One significant event on the horizon is the upcoming convention and training workshop scheduled for March. This gathering presents an invaluable opportunity for members statewide to convene, exchange insights, and engage their knowledge of the Oxford House model. A cornerstone of the Oxford House, of the Florida Oxford House's success, lies in the dedication to consistent training initiatives. Across chapters and in individual houses, the efforts continue to ensure that members are well equipped with knowledge and competencies needed to effectively succeed in their living environments. In addition to focusing on education and skill building, the Florida Oxford Houses are also actively expanding their reach. The recent opening of 9 new houses in different regions of the state underscores the demand for the supportive community and resources offered by the Oxford House model. Furthermore, the growth of the community is complemented by an encouraging trend of members stepping into leadership roles. This proactive involvement not only strengthens individual houses, but also fosters a sense of ownership and responsibility within the broader Oxford House community in Florida. In sum, the Oxford Houses in Florida are flourishing due to a combination of robust training efforts, strategic expansion, and active member engagement. This collective momentum bodes well for the continued success and sustainability of the Oxford House movement in the state. With that, we did have 3 overdose non-fatalities. It was Leon County, Clay County, and Palm Beach County since the last meeting. Thankfully, we've been working a lot with the state to get Narcan into all of the houses and to be providers, and just really inundating the houses with not only ample amounts of Narcan, but doing a bunch of Narcan trainings continuously to keep that fresh in everybody's mind, what to do in those kind of situations, and to really just be on top of it when something like that might occur. We do have our Rural Convention coming up as well in October. And these are our websites.
Thank you, Michael. Appreciate it. I just want to make note, which I generally do with your increases on a bi-monthly basis. But if some of you may recall that we were having discussions years ago, I think it was 3 years, when there were no Oxford houses in Florida. And to the credit of the state, seed money was given to Oxford House to start. And I believe the original target was 99 houses within 3 years. And now we have 173 with 1,563 beds. It's a great success story where we had none. Now we have 1,500 plus beds. And between FAR certified beds and Oxford House, we're approaching 11,000 beds in Florida. There's no state that even comes close to what we've been able to attain in terms of certified or accepted best practices houses in the state of Florida. So y'all ought to be proud for the work that you've done in the task force. And thank you, Oxford House, for coming. And thank you, FAR, for the job you do. Now let's, any hands, anybody want to comment or ask any questions on the Oxford House? Okay, let's move on to the legislation, because unless Courtney Phillips is, Dr. Phillips, are you with us? Okay. All right, we're supposed to have an ASU addiction stabilization unit update. If Dr. Phillips shows up, let me know. Thank you. So we're going to go to the legislation. Hey, 7th time in 8 years that this task force has introduced legislation in Florida that has been passed. And we had a lot of good stuff. I'm going to give over to other people to describe some of that. But first, I want to let you know what was taken out, because in our previous meetings, we discussed some sections that we tried to get into the bill. And, I've been a big proponent of a half a loaf. Y'all who work with me know that. And you don't die on hills when you can get good stuff through, you try next year. So the transient taxes, that section, because it is federally illegal to single out persons in recovery to pay a hotel tax or some kind of tourist tax. Now, interesting, and just to take a minute to explain what happened, why it was taken out. We put it in to begin with, these exclusions from transient taxes for sober homes, for certified recovery residences and Oxford houses. We put it in there as a prophylactic to prevent it from happening in the future, because my understanding is, from talking to FAR and talking to others in the business, that these taxes are not being imposed by the state or by local government at this time, but they could be. And even though it's illegal, we know that sometimes, especially with local municipalities and counties, sometimes legalities are ignored. But anyway, the legislature, both the House and the Senate, said that there was a fiscal impact. The House said there was a $4.6 million fiscal impact by leaving it in. And I said, how could there be a $4.6 million impact when you're not collecting the taxes? And you're just talking the state now, you're not talking local. And the answer was because, well, we could. So we theoretically could be losing 4.6 million. That's how sausage is made. We took it out. We're not going to die on that hill. So it's not in this year. And fortunately, it's not something that is an emergency. Now, we did have a number of public records requirements of the department that we had submitted in the legislation. Since then, we've had some meaningful discussions with the secretary and the staff in Tallahassee about making the database and making the website for the department akin to ACA in terms of transparency. So people will be able to look on the website and find out things that right now they need to request through public records, such as the license application documents, investigations of complaints and the like. So it's going to be, it's a work in progress because it takes time. And we're going to be hearing from Chief of Staff Molly McKinstry a little later in the session today about what steps have been taken and what is going to be happening in the future. So that was taken out as unnecessary at this point because it's much better not to legislate that, but to have that working organically through the department. The last thing that was taken out, if you recall, we looked at the Opioid Abatement Council, the State Opioid Abatement Council, and noticed that there were only government entities involved, either from the state side, the governor's office, the AG, and the legislature, or local governments, municipalities, the League of Cities, and the Association of Counties. And we said, there's nobody on this council who has any lived experience or has any medical experience to be able to inform, at least, the Opioid Abatement Council on, best practices, priorities, potential priorities from a medical standpoint. Come to find out during the legislative process that there was an agreement between the plaintiffs and the defendants in the opioid settlements. And that was drawn up into an agreement that there would be 10 members of the council, and they would be either state agencies like the department, the AG, legislative appointments, or local government appointments, and there was nothing we could do about it. We were not going to die on that hill. I'm sorry, Maureen Killian, if you're on in this meeting. It's one of your ideas, and thank you for that. It's a good idea, but it was not to be. So that was taken out. With that, I want to give a shout out to Jeff Lynn and to FAR for the work that they did on this legislation. This is significant stuff this year. This is one of the years where we didn't just tinker around the edges. We actually set the table for some major stuff coming down the pike. So Jeff Lynn, thank you. FAR, this is before Micah, before your time, but Michael Cabot and the rest of the board, and also Susan Ramsey and Heidi, you and Josh. So thank you for all your good work. Also a shout out to Representative Caruso, Mike Caruso, and to Gail Harrell, Senator Harrell. Every year they're carrying the water of this legislation. And again, we've had a great record, 7 out of 8 years. I know that they both are very invested in this, as is Commissioner Weiss, very invested in this issue. And we can't do it without elected officials who are going to be going to bat for these changes in the law. So with that, let's first talk about, Jeff, I want you to talk about page 3 of the legislation, talking about codifying the levels of certification in the definition of recovery residence.
Okay. Can you guys hear me okay?
Better now. Go ahead.
Yes?
Yeah.
Okay. Thanks, Al. So talking about the codification of the 4 levels, FAR was approached or became aware that there was confusion when cities started to use the definitions, the 4 different levels of care or levels of support on the FAR website against sober living providers, saying, well, this is what the FAR website says. And so when we looked at the FAR website, we recognized that all that had occurred was a duplication of the NAR standards, but that were not really directly relevant or germane to Florida and how we do things here and have historically done things here for, 50, 60 years. So what was proposed and what was adopted, of course, all this is dependent upon the governor signing this into law. There's no reason to believe he won't, but we wait for that to happen until we can, cheer a little bit. But it is exciting that we appear to be the first state in the country to have codified the 4 levels of support through NAR and FAR. And the reason that's really important is because of a few things that have happened this past year as well, or in 2023. First of which is SAMHSA recognizing the NAR levels of support as being best practices for recovery residences and sober living environments, which that speaks for itself. That recognition, but that recognition also came on the heels of federal legislation. And again, so much had passed over the past couple of years in the space that directed a review of NAR standards for purposes of determining if they're best practices. SAMHSA did that and declared them, and there's a publication that says that they released at the same time, and over a period actually going back a couple of years, but about the same time at the end of 2023, ASAM updated their placement criteria. I think they're on the 4th evolution of that, which now directly links NAR levels of housing to placement criteria in ASAM, which is a recognition quasi-medically that recovery residences are part of the continuum of care and is not just housing. And the reason that's ultimately relevant is because we've been moving towards trying to affirm what the Parity Act's desire is that mental health care and addiction health care should be treated no differently than medical health care. So by adopting these 4 levels into Florida law and having the legislature acknowledge them, particularly the level 4 level of care of support, there's other definitions that do this as well that help supplement all of this. It is our belief and goal that now Florida has recognized FAR levels of recovery residences as part of the healthcare continuum. And then the next step should be to insurance. Why aren't you paying for this? It's not like, you have heart surgery, but you got to go find a hotel to stay in. So we think, and other people across the country are in a good way flabbergasted. I don't know if their jaws have dropped that we were able to accomplish this. And it just elevated our state to be doing best practices in this space. And we're recognized as that. So everyone should really, really be very proud and thankful and gracious, or have gratitude that this got pushed through basically unscathed as written. So I don't know if you want me to stop there or if you want me to go on.
No, that's okay. We do have something called day or night, either with housing, let's put that component license out there. And it's an alternative to hospitalization is what it is by the insurance code, PHP, partial hospitalization plan. And, but the housing is not covered. So again, in keeping with what you said, Jeff, we need to be moving because housing is so important, especially for opioid use disorder, which is a long-term brain disease. Housing is a critical component of the long-term continuum of care, which will keep people, for lack of a better word, out of trouble by having them in an environment that encourages recovery. And it's not just letting them go forth after 5 weeks. You're cured like you would be doing rehab for a broken leg, and go ahead and go forth and prosper. That doesn't happen when you're really closer to relapse than you are to recovery after 5 or 6 weeks when you have been addicted, have OUD for any substantial period of time. So anyway, with that, let's go to the definition of community housing and what the significance of that is. And then I'll take questions on this section if anybody has any.
Al, can we just go up, just because they're tied together, go scroll back up a little bit to level 4? Okay, so in our conversations with Dave Sheridan with NAR, and as far was trying to redefine these or define with some continuity what the 4 levels are, it became abundantly clear, explicitly clear to us that NAR views levels 1, 2, and 3 as being on one side of the table, and level 4 being on the other side of the table, which if you look at the NAR definitions, level 4 is the equivalent of what Florida has as inpatient treatment, because nationally in other states, you can do inpatient treatment in a residence no differently than in Florida, where you have a group home or assisted living facility can have 6 people in a residential neighborhood. So NAR used that as a template for states that allow treatment being clinical counseling or any kind of services that, you know, that don't require a license. And most NAR was really based upon a California-esque standard and how they do things or do things wrong in California. So we had to redefine level 4 for us because we were having cities that were claiming we were inpatient treatment centers. What also came about as a result of that conversation was that we recognized that there were other FAR providers out there, mostly level 3, that really should be a level 4. And the distinction we were making, and that is to be made, is that, you know, a level 1 we will call the equivalent of an Oxford House for purposes of this conversation, and a level 2 is simply, you know, a managed or supervised sober living, but people are not in treatment; they're just living together in sobriety and a shared lifestyle. 3 is the same thing where people are living together in a shared lifestyle, but one or more people are in treatment, if not all of them. But levels 1, 2, and 3, or what we call, and Susan or Micah or someone chime in if I say this wrong, are resident-driven care. It's the resident who chooses where to live. It's the resident that decides whether to live in any of these houses. Whereas a level 4 is treatment center-directed housing, where the treatment center is telling you where to live. And so therefore, recognizing that and going beyond the PHP license, the day night with community housing license, FAR has decided, and rightfully so, with everyone's support, that anyone that is providing housing, and this is the definition, a level 4, is a recovery residence that's offered, referred to, or provided by a licensed service provider to its patients who are required to live there while receiving either intensive outpatient, IOP, or higher levels of outpatient care. So what we did is, while DCF has the license of day night with community housing, what FAR did is we said, we don't care about your license, because these levels, any housing tied to outpatient treatment program that is treatment center directed, needs to be a level 4 home, because the level of support is highest at that level. And there are many people who may be in PHP to IOP or other program for long periods of time, and the housing standards need to be a certain way. So that's what the definition talks about. And so when you then scroll down, so then you take that concept and you then roll it into the next definition, which is community housing. The term community housing was never defined. And so what we're trying to say now is, we don't care as far what you do or what you think you're calling it. If you're providing this level of care, we're calling that community housing. And some of the people who've been on the task force with me since the beginning may remember we talked about with DCF having, you know, IOP with community housing and day night with community housing, and then day night treatment with community housing. And so we kind of forced that without changing the definitions or rules, which says that this is what community housing is. And if you meet the definition of community housing, you are defined to be a level 4 level of support. And what that does is it takes the pressure off of FAR, rightfully so, to have people that are arguing with them, particularly the older school recovery residences, you know, I call them the old AA sober homes, that are arguing what they think they should be based upon their model. And we're trying to explain to them, based upon the statewide model, if you meet the definition of community housing, you are then a level 4 level of support, and you must be certified as a level 4 and have all the appropriate staffing as a level 4. So what those do tie together is it eliminates any loophole that any treatment center would have to try to argue that they need to be a lower level of support. And that's what that does. So those two together are very powerful tools for the state to ensure that people that are in any sober living are getting the right level of support that everyone expects.
Okay, any questions, comments? Hang on. Let's move to 397.407. This was late added at the request of the department. And Molly, would you please explain what the purpose of 397.407 is, license for the licensure process, and how it streamlines and also enables people to be able to search and find out about treatment providers more easily.
I'd be happy to. So currently, you may or may not be aware that the Department licensing substance use disorder facilities is by component. And so components are different categories like.
Molly, you're fading in and out a little bit. Kind of hard to hear you.
That better?
Let's see. It seems like it is. Go ahead.
So the current licensing structure is to license.
Do you have another, Molly, I'm sorry again. Do you have another computer on, somebody else monitoring close by? Because it seems like you may be getting some feedback.
I do not. Let me try one other thing.
Good, thank you, because we need to hear what you have to say.
Is that better?
Yeah, it seems like it is. Go ahead.
Okay, all right. So the current licensing structure for our substance use disorder facilities is by component. So we may have one location, one provider that has multiple components. For example, if they're offering both outpatient treatment and intensive outpatient treatment and inpatient treatment at the same site, they would actually have two licenses, even though it's one location. So what we propose to do and can do now under the statutory change is issue one license to a location and list the components that are licensed at that location on that one license. So it simplifies it not only for the provider, so they're not posting 8 or 10 different pieces of paper on the wall, but also for consumers so that they can actually look by location and understand at that location what services is that provider licensed to offer. It will, again, simplify the process. So as an example, we have close to 1,800 sites licensed in the state, but we have 2,720 different components. So it can be a little misleading if someone were to look at how many licenses do we have in Florida. It would represent almost 900 more than we actually have sites. So just making it a little cleaner for consumers and others to know that at this location, the provider can provide these services. It will also, I think, simplify some of our licensing duties since we will be licensing the location and all the activities apply to a single license. Happy to take questions and thoughts. I know we're going to do a presentation a little later and we'll mention this again at that time.
Any hands regarding the statutory change? Okay. With that, let's move to page 7. Down here to
Al?
Yes.
Hi, it's Courtney Phillips. I just wanted to apologize for being late to the meeting. I was taking care of a Baker Act actually from my clinic this morning. So I really apologize, but I'm here if I know you were going to do an ASU update.
Well, that certainly comes first, and we'll
sorry about that.
We'll circle back to the ASU
that's
update
fine.
In a minute. Thank you.
Yeah, thank you.
All right, Jeff, why don't you briefly talk about this section, which is 397.487, voluntary certification. There's a couple of changes. Let's start with line 159.
Yeah, this section just simply increased. Before, there used to be a limit when the law was first passed on, when we first created in 2016 or 2017 out the entire certification entity. And there was a limitation on the number of residences, dwelling units that any CRRA could oversee. That became untenable just as it functioned. So we had the law changed to allow a CRRA to see or to supervise up to 50. And as we started going through that, we realized, well, that's kind of useless too, as we kind of also realized that the CRRA, depending upon what FAR level, did or didn't have a strong or may have had a stronger or weaker influence over the residents. So what we tried to do is talk about, and this ties into something else, where if you had more than 50 residents, if you wanted more than 50 residents, you can get up to 100 with FAR's approval based on certain standards. But notwithstanding, the law said you have 30 days to replace a CRRA that's terminated or fired. And what we've all talked about in the task force is the workforce shortage we have with qualified or responsive and responsible CRRAs. And so we just simply asked that that time period be given up, the 90 days to find another one. And that includes particularly those who, you know, if you were approved for more than 50 residents under a single CRRA supervision, so you're allowed up to 100, and that person is terminated or leaves, this is just closing off a loophole that you don't lose the ability to continue to have 100 residents under a single CRRA. This just extends that time for 90 days as well. So this is really all that does, is it just says, hey, we're giving you 90 days instead of 30. And by the way, if you were approved for more than 50, you can keep your more than 50 during that time period that you're finding a new CRRA. And that's all that section really does.
Thanks, Jeff. Just to circle back to kind of like the beginning, we're the only state, I believe, in the United States that requires a certified recovery residence administrator within the context of FAR certified recovery residences or NAR recovery residences. It was an extra layer that was, I think it was 2015 when that was originally the voluntary certification statute first went into existence, the year before the task force was formed. But people have this misnomer. They think that a certified recovery residence administrator is the hands-on house manager, which it is not. A CRRA needs to be certified, is basically an overseer and administrator of a number of beds and a number of houses, which is why we've economically speaking, and I don't know if Neil McGarry, FCB, is on now. He wasn't earlier, but he can tell you that we have a workforce shortage.
He's here.
Neil, you here?
Yeah. You're spot on, Al, 100%. We're trying to relieve it in not only this area, but in a lot of our different mental health, substance abuse, child welfare, all big workforce shortages that we certify.
Okay, thank you, Neil. So what we did was, because of a perfectly good recovery residence that's certified, that's doing everything right, they only had 30 days to replace a CRRA, and then FAR was faced with the circumstance of having to suspend the license. And so it was increased to 90 days because if they're operating well, let's give the operators a chance to get the CRRA replaced. I know at the behest of Representative Caruso, because we've extended it literally from 1 month to 3, they're going to have to take action. FAR will have to take action after 90 days if the replacement isn't in. But anyway, I just wanted to add that as well. A couple other tweaks, which are minor. We've added some language. This is what I was talking to you about with Dr. Shepke earlier. This is, again, a FAR recommendation. And Jeff, you had brought this to our attention as well because Matt, it really is, it's here. It's like saying, having a recovery resident saying, I don't do email. It's just, well, that's kind of a bad analogy, but beginning January 1st, 2025, a certified recovery residence may not deny an individual access to housing solely on the basis that he or she has been prescribed federally approved medication that assists with treatment for substance use disorders by a licensed physician, physician's assistant, or an advanced practice registered nurse. Now, we've delayed the date, the enactment date, or the effective date, basically a year. Because we need to get the word out. Micah, when you hit the road, you gotta let everybody know. There has to be education here. I get it. There's a lot of, you have your abstinence folks saying that this is going to pollute. Now it says solely on the basis of, and I'm going to put my 2 cents in here as a lawyer and a prosecutor. If you have a level 1 house, okay, where you have people that are not in treatment generally they're in long-term recovery, their stays are averaging a year in the house, whether it's an Oxford house or a certified recovery residences, levels 1 and 2. You have somebody that was warmly handed off after an overdose from JFK Hospital to the addiction stabilization unit and given a prescription for buprenorphine. And then here's some literature. We're going to set you up with an appointment, et cetera, et cetera. It may be inappropriate to put a person that close to relapse into a house that is a level 1 or 2. I'm not saying it is. I'm not saying it's not. But this isn't a mandate as much as it is you just can't discriminate. You have to have another reason. And it can't be that you're abstinence only. Okay, so that's basically, any hands on that?
I have a hand. I'm sorry. I apologize. I can't find my hand button, and my apologies, but
it's okay. You go forth.
All right, thank you. So one of the most important things in what we're doing with FAR and why, all the support is helpful is about education and training as well as exposure. Because, one of the difficulties, of course, and everyone's articulated already is, changing the hearts and minds. And, as a former registered nurse, and as well as a woman in long-term recovery, I understand this. But notwithstanding that, we are not advocating FAR that recovery resident operators are physicians or licensed, advanced practice registered nurses. So, even though I happen to be a registered nurse, I would no more prescribe whether I'm going to be getting insulin or not, and have that restricted. So part of this has to do with the folks and their education. So, part of what we're doing is spreading the word like Micah and the rest of FAR, and also helping the practitioners have policies as to how to manage their clients appropriately. And, Dr. Sheshby mentioned the standard of care. Within the standard of care for the treatment of substance use disorder in 2025. And I'm sure Dr. Phillips and others can articulate this better than I, but the point is, we want our recovery residents to understand that, they're not in the position to prescribe medicine or restrict it. But we need to do what you're saying. So this is part of that. In my view, it's already, if you don't do it, it's already a violation of federal law. But, let's get everyone together and start talking about it among the people who mean well and are doing good stuff for their clients, but may not completely understand how this works. So that's why I had to give that speech. And thank you to everybody who's been behind this, Jeff, everybody else, Al, on the task force and, with the legislature, because it's really important. So thank you.
Thank you, Susan. And I will say that there is case law out there. I've looked at it, Susan, you have, Jeff, you have. There's nothing specifically, it's the analogy is it is against federal, does violate federal law. A jail can't do it. A jail can't say you can't have Matt. A provider can't say you can't have Matt. And I'd say as a business, a recovery residence cannot say you can't have Matt on the basis of just Matt. Okay.
Yeah, Al, just the Department of Justice says the same thing. This isn't. We're not making this up. As opposed to, this is Department of Justice. Like you can't do this. We're just forcing the issue in statute because what was happening with FAR, where people were being obstinate saying we're not doing it. And, you know, we're having a hard time with, you know, again, we talk about level 2 beds. They may not be on MAT, but certainly level 3. But we don't want to be in a position where anyone's saying, I'm not accepting MAT patients or MAT residents. Like, that's just illegal.
Right.
Again, I don't know how much that's going to happen in a level 2, as we said, but it's the law. It's just ADA law, black and white, you know?
And Jeff and I very rarely agree, but we agree right now.
Okay. All right, 2 more comments, then we have to move on. We have a packed agenda. So Terry, then Courtney.
I just had a question. The question was early on when we were looking at this, there was a exception form that owners of recovery residences were able to apply for an exception due to financial hardship that this would cause them to have staff trained to monitor medication in the residences. Did that go away, or is that still in existence?
Well, it says.
Al, can I answer that? That's a reasonable accommodation thing. Can I answer that?
Yeah, okay.
That's what they're talking about. What you're talking about, Terry, and again, it's the treatment and recovery community. You know, they say one thing and it goes like wildfire. There are no exceptions to this. You could always seek under the ADA a request for reasonable accommodation, saying that the imposition of a law discriminates against somebody, and as opposed to that, to relieve that discrimination, that they need to be relieved. You know, if we can modify the rule. So what a recovery residents would be saying by seeking a reasonable accommodation, I don't know from whom, the state.
No, Jeffrey.
Or, you know,
Jeffrey, sorry, I don't want to interrupt you. I don't interrupt you. You're my brother, and I love you. You know that. But there was in FAR when Matt came on the scene, and houses were being told that they needed to accept patients that were coming out of facilities that were on Suboxone. I remember specifically one owner showing me that he received a not reasonable accommodation. It was an exception that you applied within FAR.
No more exceptions.
Hang on.
Terry, that was illegal. That was illegal.
Right.
That was not allowed. That was not. That was
FAR.
Hang on.
Okay, thank you.
Hold on. I'm gonna have to mute everybody. Hello. We can't be talking over each other. Okay. Terry, you've made a very interesting point and a valid point. Okay. FAR may have had exceptions in the past, but there's a lot of stuff there's a lot of stuff FAR was doing in the past that wasn't A, best practice, and B, in accordance with the law. What I will say about, there's one misnomer that people have, there's one misunderstanding that people have. MAT in a recovery residence, it is still illegal to dispense medication in a recovery residence.
Yeah.
So what we're talking about is we're talking about a lockbox and somebody having access when it's time to take their medication to take medication. Now, I'm not sure that you need a house manager other than a lockbox that only the resident that has is got a prescription is able to access. But these are discussions down the road, when and if. You know, it may be a little bit inconvenient. If it's an economic catastrophe, well, then that needs to be addressed. But again, since there's no dispensing, there are probably ways that can be mitigated. And again, we have a year to figure this out. It does not go into effect until January 1st, 2025. So let's continue the conversation. And Courtney, Dr. Phillips, you had your hand up as well.
Yeah, I just want to say one comment. I really do appreciate the spirit of this, and that it's moving this into, you know, this is standard of care. But I also appreciate the fear on behalf of the fact that what if the patients share their meds? We need a house manager. That's going to cost money. And these are real things. As a psychiatrist, there's a behavioral element to substance use disorders, as you all know. So I would just say to Susan and people who are trying to marry the standard of care with also some guidance for the houses, I wonder if FAR could work with a team that could help develop behavioral standards that are suggested to the houses with procedures in place that follow the law, but also hold the patient accountable, patient or house member accountable, that there are rules about if you're found sharing these with other people or doing certain things in terms of the house. So I believe that there's a middle ground where you can weed out, bad practice from a provider. You can weed out maybe what the patient's choosing to do with their medications, as well as still support people who are getting evidence-based care. Because when I prescribe these medications to people, I'm aware they're an outpatient, and I'm saying it's appropriate for them to have them outpatient. So that's all I want to say. And I know Susan's a great mind in trying to marry the two fields. And if FAR had those standard procedures that were built, with some clinical backing and also lawyers to make sure it's under the law, I wonder if that would help all the houses.
Well, that's a great point. Courtney, that's a great point. And I'm going to add this. Level 3 and 4, this is one of the beautiful things about having the levels of certified recovery residencies defined, because this issue doesn't exist with level 3 and 4 because there is a house manager. Okay. Right. So we're talking about level 1 and 2. And that's why I brought up the fact that it might not be appropriate if people are living in an Oxford house, and they're all living there long term. Okay. To have somebody fresh out of the ASU with no supports to be going into a level 1 house is probably inappropriate from a clinical standpoint. So these are things that God bless, it's not going into effect July 1st. It's not till January 1st of next year. Let us continue the dialogue on this, but this is going to be the law. All things being equal, unless there's another reason that's a valid reason, you can't just say you're unmet, you're out. Just for that reason. So let's move on. I want to take a little less time on these because we got a packed, as I said, a packed agenda. But Jeff, would you describe 14, the local ordinances on duration of stay?
Yes. In short, there are some cities that that have, all cities have various zoning ordinances on how they regulate housing. What some cities do is they use the definition of family and say, well, the term family means anyone related together or some number of unrelated persons. Let's use the number 3 just as a rule of thumb. And so some cities will regulate housing that way, saying you can't have more than 3 people in a dwelling unit. Some will also regulate it by the number of turnovers. Think Airbnbs and vacation rentals, where they don't want a single family home or any dwelling unit to be constantly occupied by a different group of people for the appearance of disruption to the neighborhood. What was happening is cities are trying to wrap their hands around what they view as the continued sober home scourge in the county and elsewhere. What they're doing is they're applying these, we call these transient use ordinances, these Airbnb ordinances, saying, yeah, you can be here, but if you have your residents leaving every 30 days, you violate the zoning code. So what we did is recognizing the impact that was having directly on level 3 and level 4 homes by effectively eliminating their ability to be in, at a minimum, multifamily zoning districts, is this removed the ability of cities and counties to pass ordinances as of after June 30th of this year that would basically restrict the establishment of a recovery residence in the city's multifamily zoning district as a result of concerns of resident turnover. It's not everything that we wanted, because if we don't put level 3 and 4s in multifamily neighborhoods, then where are they going? The ADA and FHA says you can't force these into institutional environments, that violates, it's stigmatic, it's prejudicial and unnecessary. And that's something for a future discussion. The reason why this was also put in is to kind of put a freeze on cities trying to scramble while prior work that this task force has done, getting an appropriation for a statewide study is underway right now through FSU, I believe, with Dan Laumer. We want that study to be able to bear fruit so we can best position cities and recovery residences to have some kind of armistice, for lack of a better word. And so this kind of put a gentle freeze on cities trying to get in the back door where they can't get in the front door, which is discrimination against recovery residences.
And thank you, Jeff. And that's the reason why the provision expires in 2026, is because we're not standing still on these, on the 10,000 foot issues. We're trying to enact some pretty significant stuff in the next year or two. that will assist municipalities and counties in working with certified recovery residences, so that we actually have standards statewide, to live and let live, that is going to be acceptable to the local government, but also non-discriminatory and acceptable to the recovery community in terms of what we our obligation under the law, to reasonably accommodate the recovery residences and treatment. But anyway, any hands on this? Let's move on then. Okay, I think this is the last section. Could you give it the old 1-2 there, Jeff?
Yeah, basically all this is doing is we're still trying to, with law, ultimately, I guess, not eliminate the CRRA, but it has to be more expansive. What this does is basically says if you're a level 4 program that has already a lot of staff and you already have house managers, like the CRRA doesn't really do much in a true level 4 program that has multiple outpatient licenses because of the staffing that they have. So what this says is, okay, look, if you're a level 4 program and you meet these benchmarks, then instead of being limited to 100 residents under a CRRA, you can have up to 150. The thought process, and I've talked about this at length, the thought process is you have way more supervision and oversight with your existing staff than you have with the CRRA anyway. And so it's a duplicate position that doesn't do anything else. So if we don't have to keep hiring CRRAs to do duplicate work, and we can have 150 residents in a level 4 program that has all the outpatient licenses, is honestly small. I know it sounds like a lot to a lot of you, but for my clients, that's a small program. So the goal of this was, again, to help alleviate CRRA workforce shortage by allowing treatment centers that already are paying extensive staff, behavioral health techs, other clinicians, people that are interacting with the housing component intertwined with the treatment component daily, that we give them a little relief and not make them hire another CRA and give them up to 150 residents to supervise instead of the 100 that was the prior cap. Again, so long as you meet these very specific standards that are industry specific to Florida, these aren't just made up numbers. We looked at these numbers, we looked at the regulations, and so they really do match DCF regulations relating to outpatient care anyway.
Okay, any questions? That does it. Oh yeah, the rest of this that's page 11 to 35. If you want to go to sleep, and you have insomnia, I would suggest you read these pages. All it does is, because we added a definition, which is community housing, it threw off all subsequent definitions as far as when they're listed when they're referenced in statute. So they now have to go and just change the number in the relevant statute for every definition when it's mentioned. And that's what the rest of this is. There's nothing substantive in it. We can take this off the screen. Now that I see Dr. Courtney Phillips is with us, we're going to have a brief update on the addiction stabilization unit, which I got to tell you, I got to hand it to Dr. Shepke. Certainly the Palm Beach County Healthcare District, JFK, this task force for getting this model program started. And it's now replicated, I believe, in 12 different jurisdictions around the state. And I believe, and I think it's the department, or it may be the managing entities. It may be the managing entities that is, and Dr. Shepke, you can correct me where I'm going wrong here, but I think there are something like 15 or 16 more proposed sites for the a similar model, trauma model.
Yeah, thanks. I mean, I don't want to take Molly's thunder if she's still on, but yeah, this was a joint program from the Department of Health, ACA, and DCF, with the Department of Health taking the initial lead for the first 12 that really copied what we did in Palm Beach County with Dr. Phillips. I don't want to shortchange her or Dr. Andrick or the leadership for the healthcare district, as well as JFK Medical Center and Palm Beach County Fire Rescue. It was a big collaborative. We took that model across 12 other counties And the data is just absolutely phenomenal. I mean, we're really seeing good recovery from those patients. So much so that and by the way, we presented this to the governor, and he's the one that allowed it, he's the one that gave us the resources to roll it out to those 12 counties. And now we've consolidated all those efforts with DCF, which is just, one of their major purviews. And they are in the process of rolling out to an additional 17 counties, I believe is what it is. We'll be in 30 counties, not counting Palm Beach County. So technically, I guess we'll be in 31. I may have the number off by one or so, but that's going to be happening pretty shortly. So this is clearly a best practice. It is evidence-based science, and that's really what I was getting at when I mentioned the standard of care. I heard you say, hearts and minds, and it's a foreign concept to a physician. There's no such thing as hearts and minds and emotions. It's evidence-based science is what we follow and what gives you the best outcome. Clearly, this program gives phenomenal outcomes compared to the historical controls on this. So we're really excited to see this, and kudos to many of the people on this call that really helped this happen. We created a global one-stop solution that deals with all the facets of this multifaceted disease, from the mental illness piece to the housing piece to the medication piece, et cetera. You name it, peer support, all that. And it's really been a great model, and the evidence continues to build that this is a best practice. Thanks so much.
Thanks, Dr. Shepke. Appreciate that, and appreciate all you're doing, and it's as well the department and the governor. So let's circle back, because we now have Dr. Phillips. Can you do a brief update, speaking of great results and being the model program?
Yeah, so thank you, Dr. Shepke. Working with you has been awesome, and he is a real fire starter and an advocate for standard of care up at the state. So it's great to have him up there. I'm glad things are still going well with CORE under DCF. So yes, I'm here for the healthcare district, the original program, and I am going to show you some data. Speaking of data, I will share with you guys the dashboard that you've become very familiar with to show you the real-time results, which, as you see, this is data, just to remind anyone on the call, is being gathered in JFK North. And as you can see, in terms of monthly volume, we're seeing less people in 2024 at the ASU. Again, we're trying to work on that. And I can tell you that there's plans at the healthcare district to open our clinic extended hours for sure, and possibly 24/7 by the end of the year. We have strategic planning tomorrow and are still discussing that. But one of the goals is to alleviate, and possibly on the substance use side, mental health side, bring people over to be able to get started in our clinic if there's any holdup. So I don't know what's going on over there exactly, but we are seeing declining volumes. So I want to be honest about that with everybody. Otherwise, I think most of the other statistics are fairly the same. Even if we do touch someone, there's a low against medical advice rate of discharge. There's still a lot of percentage of the patients are still receiving the medication over there. We can see that from the data. So if they are over there, they're getting the medication support if we're touching them, right? So we have seen a decrease in the numbers. So that's kind of the update over here. In terms of what's going on with the ASU and the healthcare district. And again, I saw something in the chat. There is no, there are no services over there. From what I am seeing, they're in discussing with their leadership. There is medication being given over there, and they are being warm handoffed here. But again, we're seeing lower volumes, and I'm not quite sure at this time what that's about. But I know on our end, where we're working on things, we're working on programming and a lower level of care to be available around the clock more often than just 8 to 5. So that I can speak to.
Dr. Phillips, how long you've been in existence for now? 2 years?
At the healthcare district? Since 2017.
Yeah, the ASU.
The ASU started right before COVID, actually. It was October of 2019.
Oh, okay.
Yep.
Do you have any long-term data as far as
outcomes in the clinic?
Outcomes, yes.
So yeah, so what Dr. Shepke is talking about is a continuum of care. So this is the acute continuum of care that we're talking about. This is when someone's in crisis. But this is, we do something called the Brief Addiction Monitor, which is 17 questions. Remember, it's a functional outcome, and that's what the state is replicating to show how much somebody is changing over time once they hit the clinic. So they get this survey every 3 months. The last question that we added is, what are the percentage of patients with at least one overdose in the last 3 months? I want to point this is kind of our own internal mortality statistic. So we subjectively ask the patients at their first intake. 50% of them at 1 and 3 months have had an overdose in the previous 3 months. But as you can see, the more surveys are answered as the program goes on, you see that decreases. So we know if we're able to retain them on our side and keep them in services, that they usually, live longer. The other thing that we measure, here's the brief addiction monitor, and I'm going to do it by this is all real time, so it updates from our system overnight. All of these scores get correlated into a use score, a risk score, and a protective score. And actually, I'm working with some FAU partners to publish some of this currently as we speak. So we're writing the papers right now to share. But we have up to now, this was started in 2018, so before the ASU in our clinic. And we have 6,500 surveys done. So what you can see that I'm going to walk you guys through kind of an interesting, nerdy exercise, but I think it's really interesting. So initially, when I first started doing this in 2018, I said, okay, let's look at it at 0 months, 3 months, 6 months. Technically, you're supposed to do it monthly, but I'm a clinician and a practical person, and we were doing it with the treatment plan. So what we found is people readmitted frequently. They'd come 0 and 3 months. Johnny Brown would come 0 and 3 months, and then they'd leave us for a long time. And this is what happens all the time because they were either relapsing, incarcerated, maybe they were moving somewhere, coming back, but we get a lot of people readmitted, which I can show you in another statistic. So what we found is a lot of people had repeat BAMs at 0 and 3 months. They'd leave for 6 months, get repeated at 0, 3 months when they started a new episode and readmitted. The interesting thing is that we reran the numbers by, forget about what point in the time frame they're in, right? 0, 3 months, they left, they came back, 6 months later, they came back. We said, let's say, how many BAMs did the person complete? And what happens, whether they did 2 in the beginning, left for 6 months, came back, did 2 in the beginning, because most of our patients leave and readmit multiple times, actually. So what we found, which I found very promising, is the more BAMs a patient did, no matter what order or what their trajectory was, their use scores decreased, their risk scores decreased, and their protective scores, which is things like getting connected to family, getting housing, getting work, getting income, all started to slowly increase. Now you see the slope of the protective scores is a little bit lower. So protective scores are those social determinants of health that are harder to, this is things like that FAR are trying to solve, thank God. But this is what we have found over time. And this is data from 2018, and we have this has been going, like I said, for quite a long time. So this is our long-term data, and that question I showed you about mortality has also been gained since 2018, and that shows some of our long-term outcomes. I would say a couple other notables from our data right now. As you can see, this is our internal clinic at the healthcare district. We have seen a massive increase in homelessness. I don't think this is a surprise. This statistic used to be around 52% for many years. It's jumped up to 65%, excuse me, which this is what homeless is defined by: street, doubling up, transitional, homeless shelter. So it's people with unstable housing. And so this is the percent that start with us in this category. So 65% of our patients are starting with a lot of home insecurity, if you will. Other notables are that we have mostly men in the clinic, which is interesting as well. I don't know the answer to that, but you can also see that we have readmission rates versus uncontrolled discharges that we follow. So that's what I have in terms of long-term, is mostly by this brief addiction monitor.
Okay, thank you, Dr. Phillips. Commissioner Weiss, you had your hand up?
Yes.
Yeah, thank you. And I'm looking in the chat, and I think Maureen has hit on some of the points that I wanted to ask, and maybe at the next meeting we can get an update, because I am hearing the same thing, that the ASU virtually doesn't exist anymore.
Yeah. Mayor Weiss, I did update last time. Again, I do not work for JFK, but in partnership, I'm not seeing a unit They're describing, what they're describing sounds to me more like a service line. So like they're basically in any bed and they're kind of giving them medication and sending them out. So
the plan, I understand, was that they would be a pipeline to the ASU for a warm handoff. And what you're saying is JFK's kind of checked out of the marriage for a bit here, for lack of a better
I'm
analogy.
saying that, yeah, we're trying and people still get started with acute medications over there. It seems like we receive people from them every day still. The volumes are lower. And I think there's a qualitative change in what's going on over there. I didn't see it when COVID hit. I see Maureen's comment, started noticing it more in the last year.
I think the other thing to add in, what I've heard is that the emergency folks are not they're not taking them there anymore.
That's right.
And I think what we're trying to do at the district is step in and have set up a service, through our clinic, because from 8 to 5, we will do that all day and step in and try to provide some overnight support so that we can receive those patients. What does that look like? There's a lot of things under works, but having things like our own Pyxis so that we can give medications quickly to people, even if they aren't able to use our pharmacy. So
I have to say I'm a little concerned because we're sort of out there touting that we have this kind of facility but in practice it doesn't sound like we really do, and so maybe we're misleading people on what's happening.
Yeah, Commissioner Weiss, I think that we did this a while back. I had a meeting, and I don't know if you were involved in that, or I think it was Commissioner McKinley that was involved at that time. And I actually did some stats about multiple overdoses and showed that in other hospitals, there was a higher rate of multiple overdose than there was with regard to JFK. And this is back probably before COVID, actually. And now that you jog my memory, yes, it has been 5 years almost. But the upshot is they were assuring me that based on health and the welfare of the patient, that they were transporting to JFK, or they would. But I think that was just, I think it was a former fire chief. And I think that we may need to get fire rescue involved and maybe look at the stats and see where people are going. But again, that begs the question of the initial contract with JFK, and they no longer have the beds specifically devoted to this, to the opioid use disorder specifically. I don't know, Dr. Phillips, if I imagine they still have appropriate staff at JFK, or did that stop as well?
I can't speak to that. I'm not representing JFK. What I can tell you all is that on my end, on our end at the healthcare district, we need to solve this problem quickly because when it was working well, and it was a valuable service to our community. I'm firsthand, I'm in the clinic right now, and I'm disappointed that I think that there has been some sort of, I think what Maureen is saying, there's a huge change, and people might not be bringing people, which is why we might be seeing declining numbers on our end from receiving those patients. So I don't think the data lies, right? I've been on this meeting telling you guys good news data, but this is concerning. And I think it's time, I know on my leadership team, Dr. Indrich, myself are really aggressively, and Darcy looking at solutions to be able to continue something like this so that patients can get what they need and deserve in this space.
You're being very diplomatic, Dr. Phillips.
Extremely.
I don't need to be as diplomatic. But again, I understand capitalism, and I understand profit lines of profit, and I also understand change of leadership. And so things can change, and if they have changed, then we need to accept that and then move on to a different hospital chain or a different situation, because it obviously, if it's not working, and again, what point is it to have fire rescue use JFK North as a trauma model if they're not a trauma model anymore, if they're not providing the service that originally we all went to the moon over. So we really need to move on. There's a lot of stuff. This is a continuing conversation. This is new news, and this is something that we are going to have to speak about. Commissioner Weiss, I really think that we're going to need your help on this.
Yeah.
And I think that we're going to need to know what the reality of the situation is first, then get some data, and then confront the problem. So I know I have two hands up. Please.
Al, I do want to finish.
Oh, sure.
I know I'm being diplomatic, but I don't want to lose the little that is going on there, right? For the patients that are getting something done. But what I want to say is I am very solution focused and trying to move forward with what we can do here. And there's a lot we can do here, and we're moving forward with those plans. They're not fully ready to be announced, but we really want to step into this space in the healthcare district to try to have the acute coverage for this problem. Thank you.
Okay, so I didn't mean to put you on the spot.
That's okay.
Because that's why I'll speak and let people be mad at me. Okay, John, briefly, and then Terry, briefly. We've got to move on.
Yeah, thank you. Appreciate that. And hi, Dr. Phillips. How are you? So just real quick, and it's probably into the nerdy, geeky realm more so than anything. Of course, in our plan, we were glad to highlight, the activities of the healthcare district, both ASU, your outpatient work, et cetera, and the Crises Now proposal, at least as much as we know to date. You mentioned in terms of your FAU research, this relationship, if you might, between, I think, what you characterize as bands in terms of the treatment intervention. Are you going to be, there are so many intervening and other variables that can impact the BAM. Are you looking outside those beyond just the treatment intervention and either through regression analysis or whatever, being able to isolate more deeply what the impact on the BAM is?
So I think you make a very good, what you're suggesting is a randomized control trial, it sounds like, which is a clean study that doesn't necessarily always reflect the real world. So if you do a randomized control trial and take all the variables out, it's a great thing, but it also doesn't always reflect. So we're not publishing a randomized control trial. We're looking at publishing a descriptive paper in a real world setting. That has lots of limitations, but it mirrors what most clinics are dealing with, as opposed to RCTs in an academic institution often don't reflect what's being, always happening in clinics. So all those have limitations as well. So you make a very good point that there are confounding factors, but there's medical treatment, there's psychiatric treatment, and it will be described, and I'll be happy to share it with you when it's done.
No, I appreciate it. Yeah, and I guess it is the declarative statement that the treatment intervention is directly correlated to the BAM score. So, but you're also
there's multiple treatment there's lots of treatment interventions that occur here: primary care, psychiatric, therapy. All are individualized. So we're not looking at there's already papers existing that establish the isolated variables and that they're successful. We mushed it all together to make this. So.
All right.
Okay.
Thank you.
Thank you.
I see, Terry, you put your hand down. Thank you.
Yeah. No, I just wanted to say thank you, Dr. Phillips. I think the response, Al, I just want to hear from you that you're taking the accountability to find out what's truly going on with the ASU disappearing, because as Maureen politely put in her chat, we had a friend go there and was told by the hospital staff there is no more ASU, and she passed away because she couldn't get into DAF. There were no beds at DAF, and we lost her. And somebody, Commissioner Weiss, I hear you. I'm concerned as you are. You don't cut a ribbon and blast the newspaper with what you have and what you're doing with an ASU and then have it disappear overnight and nobody know about it. So if we can get the word out of what the truth is, and we can all share it on our social media platforms so we know that it's closed, we'll stop telling people to go there.
Well, let's not get let's not get ahead of ourselves, because maybe they can't go to JFK, but they certainly can go to the ASU. That's a different issue. But let's, we are going to work on this. I'm not going to drop it. You know me, I'm a bulldog when we get on an issue like this. So we have a guest here. Do we have Ms. Seward here? Michelle?
Yep, she's still here.
Yep, I'm
Okay,
here.
good. All right. I just want to, this is a 30-second intro. We have a sister state, not next door. This is Arizona. And I got an email from Dan Lauber saying the recovery residence industry and the government, it's just a mess. Arizona is a completely dysfunctional mess. And they have legislation that it's counterproductive. And can you reach out to Michelle Seward, and she is a sober homeowner, recovery. They call them sober living homes. That would be your certified recovery residence because they're licensed by the department, not by a third entity, although they may be soon. And I contacted Michelle, and I got a copy of this legislation, and my head exploded. All I can say is I don't always say, thank God I live in Florida. Okay, it's a great climate in the winter, I'll give you that. But we are light years ahead of places like California and Arizona. And I just wanted to have Michelle tell you the tortures of the damned that she's going through. And I'll tease this by just saying one of the first things they did, because the department couldn't get at the non-licensed sober living homes, they decided, you know what? We're going to change the definition of a sober living home to take out the requirement that they be alcohol and drug free. And what they were doing was they were legitimizing all the flop houses and making them into sober living houses like the good providers that are licensed and are doing the job that certified recovery residences are doing all across Florida. So with that introduction, Michelle, please give us just a couple of minutes on what's going on in Arizona.
Sure. So, hi everyone, good afternoon. My name is Michelle Sywick, and been an operator here in Arizona. We call it the Wild Wild West anymore, but since 2010, and I do own drug treatment and sober living, so all levels of care. I've certainly never seen anything like this, but just to give you a quick high level, it's almost identical to what you experienced in Florida. Just take out private insurance and insert Medicaid. And it's specific to American Indian Health Plan, or AIHP. And it's been going on for about 3.5 to 4 years. We're just starting to scratch the surface, answering or asking some really tough questions. These warehouses or flop houses, they're not, licensed sober living homes. In fact, there's no recovery going on in the homes at all. And until we cut off the funding source of these licensed behavioral health facilities, this will continue to happen. So far they've suspended 360 facilities. They've been suspended for credible allegations of fraud. And so I guess the bigger question is now, how in the world did they ever get licensed in the first place by the department? Because there's hundreds more still operating. There's criminal enterprises here. It's very dangerous. You won't see any sober living operator that is licensed come out and speak publicly about it. There's a lot of crime going on here. These networks are very dangerous. So it's just a breeding ground, and there's patient brokering going all over the state. And, just to give you an idea, these patient brokers, they send white vans up to tribal lands in Arizona. They pick up any Native American they can find. And when they ran out of natives at the on tribal land, they just went across state lines. That's why I think the FBI showed up here in 2022, is because of all the stuff that was coming in from Montana, Washington, Nevada, New Mexico, South Dakota, North Dakota. We have no idea how many non-Arizona natives are actually here and on the streets and displaced because the state has shut down 350 of these providers. So it's really quite a mess. I am super excited to hear all of the work that you've done, because my hope is that we can take a couple of chapters out of Florida and use them here in Arizona, because I don't believe we have the luxury of not getting this right the first time. You know, just to give you a couple of numbers, in 2019, this cost the state $53 million in behavioral health outpatient treatment, $53 million. In 2020, it jumped to $132 million. And by the end of 2022, it was $668 million. And I don't know who was watching the bank account. Nobody asking any questions, no auditing going on. And it's been a disaster. So that's kind of the financial side of this. The human side of this, and you'll certainly not read this in any paper. I'm not sure how the narrative has been controlled as well as it has, but there's over 300 Native American deaths in these homes. And unfortunately, because tribal land doesn't have, you know, they don't have the communication, they don't have the cell phone towers, they don't have the technology in urban areas like we do, the word doesn't get out. And it's like a petri dish, if you will, for these criminals. And it's really tragic what we have seen and the human cost. I'm hopeful, you know, NAR has been helping us. Al has been helping us. We really want to share all of the lessons learned in Florida, how we can apply those in Arizona, because, you know, it's a pretty serious thing that's going on, and you really won't have the good operators, the good actors, you know, shouting from the rooftops, because it is pretty dangerous. There's 3 bills. That's how you know it's such a hot topic here in Arizona. Let's see, 2317, 1361, and 1655 passed last night. They all contradict each other. They don't go far enough. These should be felonies. This should be prison time. Criminals don't pay fines. The fines don't go far enough. There's a lot of things that we can do better. That's Izzy, by the way. Hey, sorry about that. So the 3 bills don't go far enough. I'm hoping that we can continue to at least get in front of the legislators. NAR's agreed to come out next week and meet with the governor. There's reports that this is going to hit 2.8 billion for the Arizona taxpayer. It'll probably hit 4 billion before we're done, and probably north of 500 deaths. And we hope that this information does get out so that we can never let this happen again in Arizona. Certainly, if we don't learn how we got here, we're never going to be able to figure out how to tighten up our laws, tighten up our licensing. Because remember, all these outpatient treatment centers, they bubbled up overnight, literally overnight, and we're still asking the question, how in the world did they ever get licensed? So that was truly the Cliff Note version of what's going on in Arizona. But I certainly appreciate the opportunity to just sit in and listen to the wonderful work that you all are doing, because it gives me hope for sure that we can do something similarly here in Arizona.
Thank you, Michelle. Just regarding the legislation, it was the middle of the session before I became aware of what was going on in your state. My first reaction was, don't do something half-assed. You know, more respectfully than that is how I termed it, but you know, start a task force like we did in Florida so that you can recommend to the legislature for the next session, you know, the laws and rules that need to be changed to attack the issue. Instead, they have a hodgepodge of legislation that basically will bring the unlicensed homes into the fold and then fine them for not being licensed, when none of these criminals are going to be paying any attention to a fine. They'll close down and move, or they will just, what are you going to bleed a stone? You can't suspend somebody who's not licensed in the first place. So you don't bring them in. You know, if you can't wait a year, then I wrote some of our legislative portions that were germane and kind of like the least that you can do. And one of the things is to carve them out so that they're reported to law enforcement, and they're reported to, you know, make being unlicensed and being a flop house where drugs and alcohol are allowed, you know, make that a crime, and have the police investigate and prefer charges over to the DA or state attorney. And at the same time, go to the local government, because if they're violating local codes and ordinances, they're not protected. Those bad actors are not protected by the ADA and FHA if they're operating a flop house. What they're doing is they're exploiting vulnerable people. Well, I think you only have a week left or 2 weeks left in your session, Michelle. You know, they're not going to get it right. And one of the things that bothered me was, well, we can't make anything a crime because that's going to take the whole session to do, because we have to go to, you know, particular committees to do that, and it's too late. So don't make it worse is basically, and you're doing it, Michelle, congratulations. I mean, congratulations, because, you know, being Don Quixote is not necessarily a rewarding occupation, but you are tilting at windmills, but you'll get it right. Within a year or two, things will start turning around when people like you and bringing NAR in, bringing Oxford House in, to inform them of what, you know, and they don't have to reinvent the wheel. You know, some of that we've done here. So anyway, thank you. Any questions for Michelle? Appreciate you being here. And now we're moving on to 8, which is enhancing transparency and access to public records. And Molly McKinstry, Chief of Staff to Secretary Harris, is going to talk a little bit about what DCF is doing now, the positive steps that are being taken.
Thank you very much. So, Al, is your team going to pull up the PowerPoint I sent, or should I try to share my screen? Okay.
Oh, you don't have it? Can you pull it up? I'm sorry.
That's okay.
Apparently, we were setting up this morning, and Marianne didn't get it downloaded in time. So.
No problem. Can you see it?
Yes.
Fantastic. Let me get in the right mode here. Okay. Oops, let's start with the first slide. Okay, well, thank you very much for giving us an opportunity to talk about some of the enhancements we've made in the substance use disorder licensure. You know, we're excited about the legislation that's passed. Congratulations on getting that bill through. Very happy that we could address one of the issues that we had as part of it. So the first slide we have here is really kind of the most recent accomplishments that we've made in the program. So I do want to also get Courtney Smith on with us. She is our acting director of licensing right now. I think many of you may have met her recently. I know we've done a lot of partner outreach. So I'm calling her in on the line here. So the first area that we wanted to talk about was the conditional designations. And this is basically when we have a provider. Hi, Courtney, I've got you on speaker with the task force here, and we're going through the presentation, okay?
Okay, sounds good.
Great. And if you can put your phone on mute unless you're speaking, just so we don't get the background noise.
Yes, ma'am.
Excellent, thank you. All right, and so the conditional designations, basically we established a process that, and this was based on legislation that passed last year, that allows us to do a conditional designation when a provider is making good faith efforts towards correcting a outstanding violation, but it does not coincide, it isn't done in time for their license renewal. This gives us the ability to extend them for another 60 days to give them a little more time to come into compliance. So that's just a helpful measure for those providers that are working hard to address issues that have been raised through an inspection. The next was enhanced communication. I mentioned that many of you may have met Courtney and some of our other team members. We've done a lot of outreach in the past few months to stakeholders and providers and really tried to beef up opportunities to share what's going on with the program, to share transition issues and opportunities within the department, as well as listen to providers and address questions that they have. So this has been a really important part of making sure that we've got eyes wide open on challenges both by providers and stakeholders. And again, the types of things many of you end up working on in terms of legislative solutions. Al mentioned the component that was in the bill related to additional transparency and the Secretary's commitment that we will make sure that those things happen regardless of the legislative requirements. So we're already making headway on that and expect to have some additional enhancements in the next few months. So again, this has been very helpful listening to stakeholders. Please know our doors are always open. We've also established routine meetings with our licensed partners and the providers that we regulate. And so we have those scheduled either monthly or quarterly in each of the regions around the state. We've also provided contact information for our licensing staff as well as their supervisors and managers. So if there are ever any unresolved issues or if there's concern that the guidance or response that a party is receiving is not consistent or aligned with what some of the additional concerns may be, there is an escalation process. And so really encourage stakeholders and providers to use that. We want to be responsive, we want to give the right answer, and we want to be consistent. The other area that we've invested in is training. We have established a learning management system, which is a software solution that supports uniform training platforms around the state. We've developed 2 sessions and implemented them so far. One is in eligibility for designations and the others on fines and corrective action plans. And so far we've had over 1,000 individuals participate in that training. That's free training that's available to our providers and their staff. And our goal here is to make sure that providers understand the rules and are equipped to follow them. This is not a closed book test. We want to be very transparent with our providers about the expectations of the program and make sure that they have an opportunity for their staff to be trained as well. We expect to be rolling out additional topics and training topics in the future, and we'll be announcing these through our stakeholder and provider calls. We also will have these available through our website as well. So I just wanted to make sure that you're aware of that. In terms of corrective action plans, so corrective action plans are when we have cited a licensed provider for a violation. They're required to give us a corrective action plan. In many cases, we direct the minimum components of that plan to ensure that the facility comes back into compliance. And one of the things that we've done is created a new template for providers to respond to and present these corrective action plans. This new template really ensures consistency around the state. It's easier for the providers to follow so that we get compliant plans. It allows the providers to easily see the classification of their violations, and it requires that the provider outline the steps that they're taking to make sure that whatever the violation that had occurred does not occur in the future. Certainly, one of our goals is to make sure that when we find violations that they're corrected, but that systematic changes are made so that those violations do not occur in the future. And I'll mention one thing on the corrective action plans. You may be familiar with some recent changes we made to our licensing rules to clarify the classification of violations. And we can certainly provide those as follow-up to this meeting. But we have implemented a consistent statewide process in classifying deficiencies that we find. And those are based upon really the severity or risk they create to the clients being served, as well as the scope. So as an example, a class 1 is our most severe violation. that is subject to a fine when we identify those. The fine amount is based upon how widespread that violation may be. So if it's an isolated case where it was, it involved one staff person or one client, that may be more limited. That would be a lower fine than something that we consider to be widespread. So for example, if they have a major issue that all staff weren't trained, something terrible happened, it affected a large number of clients, or it had the potential to seriously affect a large number of clients, that would be more of a widespread violation, and the fine amounts are increased as the scope of the violation expands. The other changes we've made, we've created an online dashboard, and we'll show you some screen prints of that today. It is live. It's on our website. If you go to our website here, and we've got on the next few pages kind of showing you which buttons to click through to get to it. It's updated daily, and I'll tell you, this is a dynamic site for us. This is the place that we expect to be able to push out the transparency that Al mentioned earlier, related to your ability to see providers, to see their status, their components, their beds. We currently, and I'll show you this in a sec, have information about legal actions we've taken, but we also will be expanding this site to include more information about the inspections, the results, and the violations. So right now it has the basic information, the ability to narrow your search and sort by columns, the links to legal actions taken, and then you can download this list that allows you to manipulate it yourself. All right. So to get to the dashboard, if you just come to our DCF website and click on services at the top there, circled in red. If you go down to licensing, and then under licensing, substance abuse disorder licensing and regulation, that will take you to our page for licensing. If you look at that page, you'll see information about the program, describes components and other, has links to our rules and regulations. And then if you scroll to the bottom of the page, you'll see a dashboard. This is a snapshot from the application we use to support the dashboard through Microsoft Power BI. And you can scroll through this page. You can see it immediately defaults to a list of all the providers that we license, and you can see the name, the site ID, address, the service component. And so one of the things about the site now, I mentioned earlier that we license each component separately. So you can see here the last two items are this 1000 Hills Recovery and Treatment Center. It will be listed for each component separately because that's the way it's currently licensed. But as we implement the new legislation that passed, you'll be able to see 1000 Hills Recovery one time and all their components across that single line for that location. The next column you'll see is legal actions. So if we have a legal action that has been fully implemented, like a fine, or an emergency action like a moratorium, that will be listed under legal action. And then you'll see the link to the legal document if you want to actually see the details of that action, and which also lists the criteria that, or violations, so to speak, that led to that legal action. You can click on the little blue button there and see the legal document. And then it has the effective date of the license, the expiration date, and the bed capacity. Now at the top, you'll see the little white boxes. You can click on the drop downs, and each of those columns has criteria you can select from. So if you only wanted to see the providers in a certain county, you could pick that county at the top, and below would be displayed just providers in that county. Now, the other thing you can do, and this is we're making changes to this site almost a couple of times a week right now, because as we use it, we keep adding to our wish list. And so even since this presentation was made, we've made a little tweak. At the bottom here, you can see download list, which says current providers Excel. We've changed this, and it's now a button at the top that says Excel download, even easier to kind of self-identify the functionality. If you download to Excel, it will just give you an entire list. And of course, you can sort and slice the way you'd like. This site is updated daily. So each morning it is refreshed. And I know that many of you may be interested in looking at it. We would love your feedback. If you please let us know if there's something that you wish was here and is not here yet. It may be on our plans, and it may be the kind of thing that we hadn't anticipated. So we would love your feedback on where we go next with this. In terms of next steps, we are enhancing our electronic licensing system. So we're currently going through the process to improve usability. I already mentioned the template for the corrective action plans to improve the ability for providers to submit successful plans. We're doing some internal reworking to make it easier for our staff. We'll also be modifying the system to redirect licensing towards location instead of component, and making other enhancements to the system to make it easier to use. We've gotten some great feedback from providers and other stakeholders that it's on our list. And so look forward to any feedback you may have. I mentioned the enhancements to the online dashboard. And then we've already talked about the licensing component there. So that's what we put together for today. I really appreciated the dialogue from the meeting so far. It gave me a few ideas of things if you ask us to present in the future, we could probably cover. But thank you all for your partnership and allowing us to present today. And I'm happy to take any questions if you have time, Al.
Okay, thank you. While I'm waiting for hands, if there are any, you mentioned feedback, which is a great idea as to how the site is can be improved perhaps, or what may be lacking. What would be the point of contact for reaching out with feedback?
What I can do, let me send an email. I mean, you're welcome to send it to me. And I can share, I think I'm on the meeting notice, so people should be able to see my email, but I will also get you a direct contact. So just specifically for this as well.
Yeah, if you send me a contact,
sure.
then Mary Ann will send it out to everybody on the task force. So that everybody knows, okay, this could be improved, or yeah, maybe you'll get a few saying, hey, this is a great direction, thank you.
Sure.
You know, okay, any questions? Okay, well, can we get an update in 2 months when we have our next meeting, Molly?
Absolutely. Yep,
Awesome.
happy to do that. Thank you.
Thank you so much. Okay, now we are running out of time, but I think we can squeeze in at least the next next one. Katie, are you with us? Katie, way back. Last June, if you recall, we had the Neurobehavioral Hospital kind of introduce themselves to the task force, and I wanted to get an update, and which they're happy to provide. So, Katie, are you with us?
I'm actually here on Katie's behalf. My name is Dana. I'm an outreach manager at Neurobehavioral Hospitals.
Okay, Dana, I'm sorry. What is your position?
I'm the outreach manager.
Okay, cool. Outreach manager. Is that like a public information officer or something?
Kind of.
Okay.
I go around and spread the good word.
Okay, very, very, very good. Please give us an update. Where are we at? I saw some pretty interesting stats about your what your capacity is, which is clearly needed in the county. So go ahead and give us the info.
So we can go on to the next slide. Thank you, Marianne, for helping me with this.
Of course.
If you want, I'll go through this kind of quickly, but to give you the big overview, we are a new inpatient psychiatric hospital system that opened up about 2 years ago. It was always our goal to bring a voluntary psychiatric hospital to South Florida. All of South Florida's psychiatric hospitals are typically Baker Act receiving facilities, and we really wanted to do a fully voluntary facility. Now, as we were doing that, a psychiatric hospital in West Palm Beach called IMF was closing its doors. And we thought, hey, you know what? That's really in our wheelhouse. Why don't we go ahead and keep that open, since it's something that we can do, keep those beds. And so we actually have 2 facilities open at the current moment, one being a Baker Act receiving facility and one our voluntary facility. Our mission is to bring life-changing restorative healing to those affected by psychiatric illness by improving the way mental health care is provided. We know in South Florida, it is tough to find resources for mental health care. It's also very hard to find very, very good resources for mental health care. And that's where we were really hoping to fill the niche. Next slide, please. That is a picture of our beautiful hospital. We purchased the building and put about $10 million into it. It's absolutely gorgeous. I would love, at the end of the presentation, I do have my phone number up, and I would love, if anyone's interested in a tour, I would love to give you one. We totally gutted the inside, and it is new and fresh and clean and pretty, which isn't always what you get when you go to a psych hospital. Next slide. Some pictures of the interior. Sorry, those were just grabbed really quickly, but you kind of get the idea. Next. Why it's important and why I keep stressing the voluntary aspect of our hospital is because when you go to a Baker Act receiving facility, it's just not ideal. It's what we have in place, and we even, have a Baker Act receiving facility, but we know it's not the ideal way to treat a patient. You are oftentimes, most of the time, put in handcuffs, put in the back of a police car, brought to the hospital, stripped of your rights, told you're going to remain there for typically a minimum of 72 hours. And you're in with a whole bunch of other people that have also gone through that procedure. And the vibe is they're just not real happy to be there. So we said, what if we could create an environment where everyone in the environment has raised their hand, said, hey, I could really benefit from some mental health help, and can you help me? And that in and of itself creates a very different energy and a very different environment than a Baker Act receiving facility. Our average length of stay at our voluntary hospital is about 10 days. But the time frame is variable and depends on the needs of the individual. You don't have to stay that long if you don't want to, or we can expand it if you need it. And we provide psychiatry for medication management, psychology for group therapy and some individual therapy, social workers to help with discharge planning, psych nurses, and then recreation therapists. Next. We do a little bit of individual therapy. We do a lot of group therapy. We do CBT. We do medication management, mindfulness, expressive therapies. Topics of our groups are psychoeducation of mental illness, stress reduction, coping skills for depression and anxiety, anger management, boundaries, and then we also help with the discharge planning. Our psychiatrists really believe that gut health equals brain health. So we have an in-house chef that provides not only nutrition education, but also provides meals that help with that philosophy. So all of our meals are made in-house. It's not, Cisco junk that's brought in and reheated in a microwave. All of our patients are also given psych-safe cell phones at this hospital. That way they can stay connected with friends and family. We have twice daily visiting hours. We have their discharge planners, and we can even provide transportation to our hospital. And once you're there, we have indoor and outdoor groups and activities. Next, please. To come to our voluntary hospital in Boynton Beach, there is certain criteria that has to be met. This hospital does require insurance. We do accept all insurances, including Medicare and Medicaid. If a patient has deductibles or copays that they are concerned about, we can still treat the patient and work out a very affordable, low-cost payment plan for them. Patients must be able to complete all of their ADLs, activities of daily living. These are things like the eating, toileting, dressing, bathing. We can accept wheelchairs. Patients must come in voluntarily. So sometimes we get a patient that says, well, my husband made me come, but I don't really want to be there. That's not voluntary. They have to express that they want to stay with us. They must be able to legally sign for themselves and make their own decisions and be willing to engage in the treatment activities. We cannot at this hospital, since it's under the voluntary nature, accept Marchman Acts or Baker Acts or diagnoses of dementia or Alzheimer's because of the fact that no longer makes them truly voluntary. As we know, dementia and Alzheimer's is a spectrum. So if they're early on in the spectrum, we can work with that person. But if talk therapy is going to mean nothing to them, then it offers no value. Okay, so this is our other hospital. This is a Baker Act receiving facility. This used to be called the IMH back in the day before we took it over. It was a hot mess when we took it over with no furniture, punch marks in the walls, and just a very sad place that no one would ever want to be. We put money into it. We've made it fresh, all new furniture, coats of paint. The care is excellent because it's a lot of the same practitioners that go back and forth between our voluntary hospital and our Baker Act receiving facility. If you can go to the next slide. This hospital, our Baker Act receiving facility in West Palm, accepts all insurances again, including Medicare and Medicaid. At this hospital, it's unique because we can also accept patients that are uninsured, so we can give care to the uninsured. The average length of stay is typically a little bit longer than the normal 72-hour hold. Our average length of stay at this hospital is 4 to 5 days and offers mental health stabilization. At this hospital, we also offer IOP. So for anyone in the West Palm Beach area, we can provide transportation. IOP does require insurance. It's 3 days a week, Monday through Friday from 9 to 12. Patients can pick whichever 3 days they like. And this is new news. We haven't announced it formally yet, but we're in the process and we can already kind of work with it, is we have developed a CAC, Crisis Assessment Center. This is particularly interesting for my police force out there. What it is if I can give you the concept, the idea is to be an emergency room for psych patients. So if you just if someone is going in a crisis and you don't know what to do with them, you can bring them to us at our assessment center. We will put them under observation, and then we can decide whether we need to Baker Act them ourselves, or whether if they were brought in under a Baker Act and after observation, because sometimes things get escalated. If after under observation we find it's not really needed, then we can remove the Baker Act ourselves. We will be able to keep a patient under observation. We can reroute the patient to a more appropriate facility, such as a detox or substance abuse. We can give resources. So it's kind of a catch-all place where if you don't know what to do with someone, you can send them to us and we'll take it from there. So that's exciting. We haven't formally 100% gotten there, but we're in the works. And we're going to be gutting our entire lobby to accommodate this space in our West Palm Beach location. Next slide, please. We do offer intensive outpatient services. Once again, it does require insurance. That's for patients who want to continue their care after being with us or who don't want to go to an inpatient hospital stay. This is an alternative. Once again, 3 times a week from 9 to 12. Patients can pick whichever days they want, and we are able to offer transportation. Next slide. Other considerations I just want to throw out there is patients would need to present to us with primary mental health issues. We can manage a co-occurring substance abuse disorder, but we are not a substance abuse or rehab or residential program. We offer psychiatric treatments, not medical treatments. So if someone needs to address their medical issues, they should go to a medical hospital first. We do have a medical nurse practitioner who can provide basic care, but if there's anything more extensive, they really need to go to a medical hospital first. But how the process works. Patient can present in person at either of our hospitals for a free assessment. Our staff will then determine if the individual is appropriate for admission. If they come to North and they'd be better at South, we can then provide transportation to our South location. If they come to South and they really need to be Baker acted to North, we can accommodate that as well. Once admitted to us, the individual would work with us and our multidisciplinary treatment staff during their stay to achieve stabilization and safe discharge. Our staff is made up of licensed professionals across all the disciplines. Next, please. And we strive to help individuals learn to shift their mindset to find the hope and strength to propel them towards recovery. When I is replaced by we, even illness becomes wellness. Next. For a referral line for either hospital, this number is available, 561-299-4305. And you can call and talk to us about a patient that might want to come in, and we can help facilitate the process and make it smooth for them. Next, please. Any questions that anyone has?
Thank you. Terry Shapiro, you have your hand up. What's up?
I wanted to answer your question about what Dana's job description is, Al. She's a person that answers her phone evenings, weekends when I've needed her, when I've had cases for neurobehavioral. She's a phenomenal resource in the community, and we're grateful and lucky to have her here today. And great job in your presentation, Dana. We're glad you're here.
Thank you, Terry. I appreciate it. That's very kind.
That's an outstanding reference, Terry. Thank you.
On the next slide is my contact information. So anyone, please, that is my cell phone number. Feel free to call me. I can help facilitate the process. I know it can be a little daunting the first time you want to refer someone in, and I can just kind of give them that VIP treatment and make sure everything goes smoothly.
Okay, any other questions? Comments? Dana, thank you so much.
It's my pleasure. Thank you all. It was a pleasure meeting all of you.
Now, I know that Ann Berner, who is supposed to present the launch of the central receiving system and some other matters with regard to Southeast Behavioral Health Network, she got called away. Is there somebody from CEFBEN here that is going to present or not? I guess we'll do this, then we'll have this in 2 months at our May meeting. So we're actually early. We have basically just, we're not going to go into depth at all about next year's legislation or about the statewide study, because the study is really just beginning. I know that Dan Lauber was on in the meeting, but he had to be called away. We were going to have an April meeting, but I don't think it's going to be productive. I think we need another month for the study to get pretty much, if not completed, at least nearing that. So we'll be dedicating the May meeting in large part to discussing legislation for next year and discussing the study, the proviso study. With that, does anybody have any comments that they'd like to make about anything that we've had going on today, or anything that we haven't reached on the task force? Boy, I missed it by a mile. I thought we were getting out of here at 4:30. Not that it was a short meeting. Now, there are going to be a lot of people. I don't know if John's still on the meeting, but yeah, John, I see you there. We've got a pretty big deal going on tomorrow. John, you want to give us a 2-minute primer on what to expect, and also how many dollars did the Opioid Abatement Council grace Palm Beach County with approximately that we're dealing with?
Well, Al, as you know, the board in November 22 had approved what was the then steering committee 2022 plan, and simultaneously in November 22 formally established the advisory committee with ex officio and public members with a couple of specific charges. One is the annual plan update, inclusive of recommendations more broadly around services and more specifically around opioid settlements. So what will be taking place tomorrow as an initial beginning of a public review period is a discussion of that 2024 plan. As part of that discussion is a public comment period, but we have also etched into the process, Al, as you know, a public comment period through Friday, March 29th at 5:00 p.m. And then the schedule is as of April 11th, we will bring the plan again before the advisory committee for review and hopefully approval of a finished product. So again, there's broader recommendations and then specific recommendations per the charge of the resolution with respect to opioid sentiment. The amount anticipated out over a 18-year period, I believe the total is just north of $120 million, I think it is, and that is through two specific funding streams that were created as part of the overall opioid settlement that the state had established and through MOU both at county and local level. So I'm going to stop speaking now, Al, and I will put a hyperlink to the plan and hopefully insert the public notice as well. I think I should be able to do that now in terms of a file and, you know, again, the open, transparent process beginning tomorrow at 2 o'clock at Mandela Healing Center on East Avenue at their community room.
Yeah, John, you better bring extra chairs. I know how small that place is.
I feel you, Al.
All right, thank you. Dr. Vinokur, Lori, what you got?
Yes, just one thing. You know that we report on this each month in our alliance meetings, and just to let you know, I know it's not your problem or Marianne's, but the website, when it describes this committee, it doesn't have the F on the end. It's just SAART. It's just this SAART. They don't have the F on the end, just to let you know. You have to just fix the website, okay?
Well, yes and no, because if you look at task force as one word, then it's a T. And it's much easier to say SART than it is to say Saartf.
You know, you're right.
So
I did think of that,
I'm being an
when you
anti-bureaucrat.
write it to us, when you write to us on email, you always put the F on it.
I do.
So just for your information, anything, it's okay.
Okay. Well, I think about that every time I see it. I look at it, and I always say, I'm not adding the F, but I understand that I'm probably committing grammatic heresy. But you know, thank you. Marianne informs me that it is she who's sending it out with the F added at the end. So,
okay.
But I will tell you on no uncertain terms, we're not going back to the sober homes task force. That's not.
Oh, no. Okay, great. Thank you so much. Great meeting.
Okay. I noticed that Whitney Van Arnhem and Natalie Kenton are on the meeting here, and I think that probably we should do an update on the OD2A. Whitney, do you want to speak for a second? I mean, would you like to do that? Is it you think it'd be helpful? Because I'd like to hear where we are now.
Well, I would love to give you an update next time. I wasn't really prepared.
No, not now. Not now. Don't worry about it. I would never put anybody on the spot like that. I'm thinking of either the next meeting, or if we're bogged down with, not bogged down, but if we're concentrating on new legislation, and we're also, I want to revisit the ASU and the JFK marriage. Yes, let's put you on there, and if we don't get to you, then at least we'll get to you at the next meeting in July.
Sounds good.
Great. Okay, with no other hands up, no other comments, thank you so much.